So good to see you.
Yes, nice.
Yeah.
Good evening, Endo Summit Live, and welcome to Teen Night. Tonight, we're talking all about teen endometriosis, and also we hope a little bit about teen adenomyosis because that can happen too. I am welcoming our West Coast team. Joining us for the first time is Rayan El Kata, which I'm sure I pronounced wrong, but go ahead and introduce yourself.
You introduced me correctly. You
Right.
did it so well, Sally. Thank you. Hi, everyone. My name is Rayan Elkata. People call me Dr. E for simplicity. Background in training OBGYN, followed by a fellowship in minimally invasive surgery with Dr. Fur and CY Lu in Chattanooga, Tennessee, and then transitioned after that to academic medicine with University of Illinois for around 8 years. Was a program director at that time, taught residents on the assessment of chronic pain and how to think about endometriosis, and then transitioned into private practice, joined Dr. Iris Orbach in her practice in Los Angeles since this past October. So fresh to the West Coast. Loving
Yes,
it.
we're excited to have you. Also joining us is your medical partner, Dr. Iris Karen Orbach. Dr. Iris, do you want to go ahead and introduce yourself?
Sure. So my passion is endometriosis. I did a fellowship with Harry Rich and CY Lu, and I've been performing endo excision for almost 2 decades. I can't believe I'm saying that. My big focus and passion is a multidisciplinary, integrative East meets West, mind-body approach to healing, really trying to understand all different disciplines of medicine to try and figure out what's going to help endo patients kind of beat endo. And so I love collaborating with all different types of, physiatrists, pelvic floor PTs, urologists. Like today, I had a big case with a cardiothoracic surgeon, gastroenterologist, and really mixing to help endo patients because endo is a systemic disease. So multidisciplinary plus a great endo excision. That's my passion.
Yes, one of the most passionate there is about what I call whole body care in endometriosis. Fun fact, we really started our practices well, you were in practice already, but I started my practice in New York with you many, many, many years, so many years ago.
Mhm.
So many, I look at it this way, so many dogs ago, because I remember what dogs I had when, right? Okay, so when we're talking about endometriosis, a lot of people used to call it an old disease of working women. But I think in your practice, you have found that that's not really true.
Correct. I mean, we
Correct.
see so many teens, and maybe because that's been such an area of mine that I learned when I was working with CY Lu. He told me over the OR one day how he was operating on a mother, and then the mother brought her daughter and said she must have been like 13 or 14 and said, my daughter's exactly how I was at her age. Can you do a laparoscopy on her? And this was when the optics were terrible. And I remember CY saying to me, everything looked normal, but I did excisions in high yield areas, like in the cul-de-sac, uterus sacrals. And he said, lo and behold, it came back as endo. I'm sure if he had the optics today, he would see tons of endo. And ever since he mentioned that to me in my fellowship, my brain just started like really thinking, where does this disease begin and how can we pick it up as early as possible to allow those who have endo to live their lives to the fullest?
Absolutely. And Rian, what are some symptoms that you see in what I call early on endometriosis?
Yeah, that's a good one. So, what I've seen in my practice and here as well is the severity scale of cycles. Like they start when they have their puberty and menarche starts, The severity scale of the cycle is a big factor. So what I tell parents in general is you want to look at your daughter's menstrual cycle as a vital sign. So if there is severity, if there is missing school, if there is missing social functions, if you're missing on life because of a cycle, something's not appropriate. So that's, I think, the biggest component. And then there's a whole lot of other symptoms as well, nausea, some associations with other comorbidities, but the big one is severity of cycle, dysmenorrhea to be specific, painful menstruation.
Now, I think the big one is stomach aches.
Yeah.
Iris, how often do you? I actually see stomach aches in teens more than periods because they normalize the period pain. What do you see that connection to stomach aches and teens and endometriosis?
So what I often see is I take the history. I usually, let's say the parent is in the room, or I ask them, did she have stomach aches as a kid? Like, was she a sick kid? Did she go to school? Did she miss school? And then I ask them about, constipation, diarrhea, bloating, gut issues. And typically what I see is that those symptoms are preceding one getting her period at least 2 years beforehand. And very often, I get the history of, yeah, starting at 5, she was constipated. Even potty training her was hard, or she always had a tummy ache. We took her to the pediatrician all the time. And then we took her to my GI and she was diagnosed with IBS and no one could figure this out. So I do get the history of the GI stuff, but that's because I'm asking that question. I don't think patients are self-reporting it. I think they're self-reporting, oh, I got my period and it's painful, or I have, like, they describe symptoms surrounding their menses.
I think they self-report. They do it like this. I have stomach aches and bloating, but it's only because I eat junk. Or
Yes.
they always have a almost a self-blaming because
Yeah.
there haven't been answer. My other favorite is, oh, I don't have any bladder issues. It's because they drink a lot of water. It's
Yeah.
never the water.
Yeah. And I think what's important, like when patients come to Iris Wings, what it's so important is for them to witness themselves and to not blame themselves for their symptoms or their diseases. And that's why we tackle it from a whole mind body approach, because I need to reverse the way that one is beginning to think about themselves in the context of the disease. You're not causing yourself to need to urinate 2 times at night and 15 times during the day. Or it's not the food that you're eating that's causing the issues. There's already inflammation in your body from those endo implants that have affected the intestines. So maybe you'll eat a little bit and you'll have symptoms, but it would be normal for any teenager to be able to sit there and eat a bag of Doritos, like that's what they do. I mean,
That's
I
what's right.
those and Pringles and Cheetos, right?
I think endometriosis robs a lot of teens of being who they are. What do
Yeah.
you think?
Fully agree. And it breaks my heart. And that's why, both Dr. E and I love working with teens, to pick patients up early.
Yes. So, we talked about that, if they have heavy periods, how do you differentiate? Because most teens will go to, usually not to insult the nurse practitioners, but they'll be seen by a nurse practitioner who tells them cramps are normal in the beginning of your period. Rian, how do you like differentiate between what could be endometriosis and what a lot of people claim are adolescent hormones working themselves out, which I've never seen that happen, but I've heard it so many times.
Yeah, that's in my opinion, you're just simply not stating the facts. Like if you use that premise to normalize their symptoms, you've already misdiagnosed what could be happening. So if the question is, what's the severity of pain slash flow that we are alarmed at? Is that your question?
Yeah, well, what's the line between like I have my own line, but what's the line between like a normal teen period and a not and a possibly endometriosis teen period?
Yeah, so there's two factors that I look at. I look at flow, heavy flow, and I also look at pain. The pain and the heavy flow, that combo increases your risk of having either adeno or endometriosis specifically. So those are the two factors I look at. In terms of parameters, I mean, I've not done this long enough to give you numbers, but I think Iris can weigh in there. But those two factors are big on my screening questions.
And go ahead, go ahead.
Yeah, so I maybe because I have two daughters, I speak to my patients who are teens like in language that I think my teen when I had my kids were teens that they would understand. And I simply ask them like how long does it take? How many pads do you soak through in a typical day? So I understand how heavy their periods are. So if they're soaking, oh, go ahead. Were you going to say something?
Well, you're in California, so I'm sure this has hit you
Or
there.
their Diva cups,
Now
or
they answer me, they don't use pads. So they're Diva
yeah,
cups. So
yeah.
what is normal Diva cup changing usage? You're the
That
first. You're gonna announce it first.
I don't know. That I don't know. But whether it's a pad or a tampon, like if they're soaking through a super tampon or pad every hour, that's way too heavy, for many hours and many consecutive days. And then from a pain perspective, I think I usually ask the teen, like, what is it that they love to do? Let's say they love to dance, another one loves to do theater. If they're not engaging in dance or theater or those things that they love, the pain is too much. That's kind of how I figure out the bleeding and the pain.
Excellent. Okay, so the teen makes it to you. What are first steps? Doctor,
Yeah,
so by the
let me
way,
go.
you guys may not know this because you don't stay at home and watch our series so closely yet. But this year at the Endo Summit, we're only using first names because we're
Nice.
trying to change the dynamic between like the white coat doctor and the patient, whatever. So don't be offended that I'm using your first name. So
No, no, go for it.
yes, so all will be revealed in a week. But Rayon, what are the first steps? Patient comes to you, you suspect endometriosis. Do you dive right into like a huge, massive excision, or what are your first steps?
I think the first step is breaking the ice. Teenage, adolescent patients, it's awkward to come see the physician. It's awkward to talk about this intimate part of their lives, especially when they're coming in with a parent. And so the key initially, as we in medicine say, history and physical, the key is history, but also breaking the ice first to create that rapport with the patient. And focusing on the patient. This is all about her, the adolescent, despite presence of mom, dad. That's important, but this has to happen. The communication happens with them and obtain their permission to have their parents part of the discussion and explain to the parents that your presence is appreciated. We may need a private discussion. We will incorporate you in the discussion of next steps, but allowing the adolescent to have that privacy in a very non-threatening fashion is in my opinion, the first step. And then subsequently you go into the full history of all the systems involved in the pelvis, so bladder, bowel, pelvic muscles, sexual function, diet, all the things that we ask about. And then in terms of moving them across into the assessment, not everyone requires a pelvic exam, and it's not something we routinely do for teenagers. We might do an abdominal exam, request an abdominal ultrasound, if they feel comfortable with more assessment, perhaps. But in general, the assessment itself does not change your management of what you're going to offer them. And so why take them through a pelvic exam if it's not absolutely necessary? That's my approach, and I think everyone who treats adolescents with endo has a very similar approach.
Yes, Iris, what are some of the assessment questions that you ask, and what is it that you're looking for with those questions?
Yeah. So, starting with I asked like those gut questions that I had previously mentioned, like have you ever seen a gastroenterologist? How long are you sitting on the toilet for? And I always preface it, no number's too short or too long, because someone's going to be embarrassed to say I sit on the toilet for half an hour. And then let's say they say a half an hour, I say, do you sit on the toilet once a day, 4 times a day? Because I don't want them to feel embarrassed if they're going to say 3 to 4 times a day. And then I ask them, like, do you have to move around on the toilet to have a bowel movement? Do you ever need to use a finger to have a bowel movement pass? Do you ever have blood in your stool, like hemorrhoids, telling me that there's constipation? So I ask them a whole host of gut issues. I ask them painful periods, pain any time of the month, the location of the pain. I ask some urological questions. And then I like to get a family, well, to start this off, I always ask them what is their goal of the appointment. That's how I begin, to make sure that I meet their goals. But then I ask family history, because I can get a lot if the mom's like, oh, I have endo, or my sister has endo, or the grandmother has endo. Right there, we know there's a 70 to 100% likelihood that that patient who's in front of me has endometriosis. I also ask for a history of autoimmune diseases in the family, because if there's all of these autoimmune diseases on one side, and that's the same side where there was maybe pregnancy loss or fertility issues, or, oh yeah, my sister always had gut issues, or there's like this whole side, chances are that increases the likelihood that that patient also has endo. And then from a physical exam, like Rian said, I just do an abdominal exam, and I can just tell if there's asymmetry of the abdominal wall muscles. If one side is on guard and the other side is loose or looser, or one side's more painful, the other's less painful, I know that the uterus or the uterus sacrals is pulled to a side. I don't need to do an internal exam. So just by that, patients have they're starting to believe their symptoms.
What do you see the connection of migraines to teenage endometriosis? I know this is a little tougher one.
Not too tough, Sally. So I'm gonna throw some statements from studies, okay? This is just like what's out there in the Western medicine. So to add on to what Iris mentioned, risk factor assessment. So family history is a big one. Number two, if they've ever had a history of obstructed outlets, so vaginal septum, imperforate hymens, things like that.
Oh, I didn't know.
But when it comes to migraines, so adolescents with endo have a higher risk of comorbidity, aka these are present with endo. So headaches, mental health related issues, and physical health related issues. So chronic fatigue syndrome, um, fibromyalgia, things like that. So does that answer the question?
Yes, absolutely. And what do you do with we get this one a lot. The teen, I wonder if it's changing because I don't have a teen, obviously, but teens are always told, oh, it's PCOS. Long before anyone, you're shaking your head. People are still saying
Ah,
this. Yeah. Come on,
I
tell us
hate
the difference.
I hate PCOS. I
yeah.
hate
Yeah, it's
hearing it.
not I'm not a fan either,
I
but
hate hearing it. I hate hearing PCO. I hate hearing PCOS. Iris, I'm gonna let you go first because I have
Yeah.
things to say. Go for it.
Yeah. I mean, PCOS does not cause pain, period. PCOS causes irregular menstrual cycles, maybe some extra hair growth you can have, but you don't need to have on imaging like a string of pearls on the ovaries. You maybe have some insulin resistance or metabolic type syndrome, but PCOS does not cause painful periods. Period. Period. I don't know why
I
all
just
the doctors are diagnosing painful periods as PCOS. Like, where did things go wrong in medical school that they think that?
I don't know. Was there like a convention where they said if a teen comes to your office? Now I have both, right? So like, and
Yeah,
I never had the string of pearls configuration, and
right.
I also never had excess hair till I went through menopause. So like, you don't have to have everything with
No,
PCOS, but
correct.
the painful periods is not usually PCOS. The bloating, not usually PCOS. I don't know. I still think there was a convention And all the teen must be that. Rayon, you have a commentary on PCOS?
Well, yes, if we think about the physiology of what's happening, they're not ovulating. And so they end up with the cycle of constant development of follicles in the ovary. When you ovulate, everything kind of goes into become a quiescent, dormant phase. So if you're not ovulating every month, on average, you might be making more estrogen, which is how PCOS works. That might feed into the endo pain theory, but there's no correlation that if you have PCOS, it's automatically diagnostic if you have endo as well. Unrelated, completely unrelated.
And I don't, unrelated to just teens. Do we know how many? I don't. Do you know how many have both? I don't
Yes.
know the statistic.
So, endo, what we
Right.
call whatever 10% or whatever, 8 to 13%. And PCOS, I think, is 12%. Or it's like two not uncommon things that can overlap. Or is it 13%? It's about the same. I'd have to fact check that. Don't
Yeah.
quote me on
So
that.
I took some social media class, which they didn't give me like the greatest tips in this social media class. It was kind of a waste of time. But they told me the number one thing I should be posting on was the correlation between PCOS and endometriosis. That apparently was the most searched thing, but
Interesting.
yet I have not posted on it once because that was that class. But so person comes to your office, what's the first thing? You've done the exam, you've done the history, you suspect endometriosis. Now are you running to surgery, or what are the steps long before you go to surgery?
So I'm assessing them multidisciplinary, right? So if they have gut issues, which chances are they do, I'm doing a gut assessment. I'm sending them for testing for small intestinal bacterial overgrowth and maybe working with integrative nutrition potentially. So I'm getting the gut health better. I get them into, it depends on what their bladder symptoms are. If they're urinating 18 times a day, getting up 3 times a night, and they're living on like LaCroix or Perrier water and coffee, maybe interstitial cystitis is aggravating their bladder. Are you drinking LaCroix in your
No,
endoscopy?
even worse. I have like a berry powder in here.
So if you have LaCroix and berry powder, you get the
Right.
double whammy for IC. So if I'm suspecting IC, I speak to them about some of the trigger foods. Again, trying not to limit and restrict. I'm trying to like expand the things that they can have and have them understand the things that are irritating them. If they seem to be um like very upregulated or anxious, I explain to them that like 90 to 95% of serotonin comes from the gut. So if we can fix the gut by treating the SIBO or large intestinal dysbiosis, I often see the mind-gut connection improving and their anxiety typically improves. I get my patient into meditation and mindfulness. I give them different apps based on what's working. Again, I'm meeting them where they're at. If they tell me I hate meditation, I'm not going to have them meditate. I'm going to figure out what is mindful for them. And then I have them, if I want some imaging, I'll send them for an abdominal ultrasound. Typically at Iris Wings, we see them back or roughly around 4 to 6 weeks afterwards. Maybe they've done one or two, gotten into PT. Maybe they went for their SIBO test. Maybe they went for an ultrasound. And then we kind of see like, are you better with the mindfulness? Like what's happening with the PT? There start to be kind of to begin an awareness of their bodies. And the patients start to understand that pain can be from multiple places. And ultimately, I explained to them that it's like a game of dominoes. Like endo's the first domino that knocks down the tight muscle domino, that knocks down the, dysbiosis domino, that knocks down maybe the IC domino. It's not all linear like this. And I work backwards, and then we do a good surgery when is convenient for them. We don't push them into surgery, but I do think excision is a really important part of treating them. And then they continue, the gut stuff, the PT. So I approach them in a similar way that I approach adults, but more in a more fun way.
Rayon, when, if ever, do you start with maybe some birth control pills?
Oh, great question. So I'm on board with a lot of what Iris mentioned in terms of the non-traditional downregulation. So in general, I will recommend starting with anti-inflammatories first, That's your first line therapy. There's no superior ones. They're all pretty effective if it's going to work. And then the second line or first line hormonal treatment is going to be some form of birth control. So contraceptive, estrogen, progesterone combo, um, preferably in a continuous fashion for a good 6 weeks. If we can get more, up to 3 months, that would be ideal, just to give a trial adequate time for suppression. We educate them a ton about suspected side effects. So the bulk of the encounter is educational, whether it's downregulation via non-traditional means or hormonal suppression. And then we give timelines so that we can improve compliance with the plan that is tied into their goals as well. So that's the first line, an anti-inflammatory along with suppression with combination birth control.
Are there birth control pills that work better or combinations that are maybe more teen related? Do you give something that has a little more progesterone? Do you give something that has more estrogen? Does it have to have a perfect mix? I'm not, by no means am I a birth control expert, but
There's
I'm
so
wondering.
much there's so much data out there. What I've collected in the past few years of my own research is there seems to be a tendency towards progesterones that are more effective. So some of the progesterones on the list, and this doesn't mean I adhere to it, but I'm just giving out options. So medroxyprogesterone acetate, which is injectable. Some of it's oral also. You have norethindrone acetate, anywhere between 3.5, 2.5, sorry, up to 5 milligrams a day. In the adolescent group, it's more 2.5 milligrams, so the lower dose. Drospirenone, Dynogest, to name a few, but these are all present within the progesterone family. And the benefits are that they're anti-inflammatory, anti-angiogenic, so no new blood flow to the endo implants, and anti-proliferation effects, those progesterone specifically.
Can I
Yes. And
mention something, Sally, about that too, just for teens? I think what's so important is just to counsel teens about how important it is to take whichever pill that they're on at the same time every day. I know it's hard as an adult to take something at the exact same time every day. So, I explained to them that we want like a steady state of hormones. And if they're like 4 hours late, take because a lot of teens will say, "Oh, I just take it at night." Well, what does night mean? It could be 9 p.m. or it can be 2 in the morning, right? But what happens is the hormone levels dip, then that signals the uterine lining to shed. Then they spot, then they cramp, then they're in pain. So I'd always tell them just to try and find a time. Are you eating dinner at the same time at 6 o'clock or 6:30? And I tell them to set their phone alarm at like 6:30, 6:31, 6:32 for 5 minutes with the most obnoxious sounding phone alarm. And then the teens have fun choosing like the worst sounding alarm, but that usually gets them to take it at the same time every day. And I think that compliance is so important. Otherwise, they tend to cycle through one pill, then the next pill, then the next pill. And by the time they come and see us, they've been on 7 different pills and they say nothing works for them. One thing I want to also throw out there is that medical management for anyone who's listening is not preventing new growth of endometriosis. The disease is continuing to progress while they're on the birth control pill. So birth control is not a substitute for surgical excision, which is removing the implants. Birth control or medical management is treating symptoms of the disease. So I think
right,
that's
but not
so
every
important.
teen wants to run right into surgery, right?
Correct.
Right.
Exactly. But just so they understand that.
Yes. Okay, so it comes that time in the patient's life, they make the decision to have surgery. In terms of the actual surgery for a teen, what might be a little different in terms of the surgery than an adult? Do you automatically do a peritonectomy? Do you always do remove the appendix? What sort of extra stuff are you doing for the teen?
I don't think we always do always any with anyone. I think what's really important is that we really individualize the care for the patient and we want to make sure what are their goals and we're helping them achieve their goals. Um, and I think that that's really important.
Yeah, and one of the things that I think it's more tailored to the younger patient with endo, whether it's adolescent in the early 20s or 30s who have not had children per se, is we counsel them a lot about the effect of endo on fertility. So, in the younger age group, adolescents specifically, if we're going to do surgery, we're going to assess their fertility and their tubal status at the time of surgery. So, shoot some dye through the tubes, confirm they're open, just to have a baseline for which they can compare to in the future if anything changes, whether they want to pursue childbearing or their plans change specifically. So at least in our practice, we're assessing their egg reserve and we're also assessing their tubal function at that time. That's just an additional thing that I mean, I think of actively on someone who's not yet had pregnancy or is in their teenage years as an assessment as well.
Yeah, a lot of preventative, like, so they're aware if their ovarian reserve is lower, maybe they'll consider egg freezing if that's something that interests them. So we do it long before they come in saying, I've been trying to get pregnant for 2 years and I haven't been able to. Like we're preventatively thinking of these before it happens.
Right. I also think it prevents that teen in some ways from becoming, I'm never going to get pregnant, because you can look at status and pregnancy may be a challenge later on, but it's not a never, depending on what the status was at that time. Yes. Sorry, she was into something in the other room, so I
So
had to interrupt.
cute.
So yes. So and we had a big discussion on the appendix in endometriosis. Why might you take the appendix in a teen? As if we hadn't, we had a full hour on this one, but let's hear our teen experts talk about that. Rayon, why might you take the appendix in a teen?
Thank you. So I get this question a lot, and there doesn't seem to be a hard recommendation for appendectomy on everyone. However, if you tailor it, so why would I take it out? If I see active endo on it, it's coming out. I cannot safely cut endo off the appendix without causing potential appendicitis in the process. So I can't leave it behind if there's endo on it. It's simply easier to remove the appendix as a whole component if there's endo on it. Now, what if there's no endo on it? Iris has published this study. We've had a bunch of papers come out from series looking at patients that we've operated on in fellowship who had a visibly normal appendix with an abnormal path report, and 20 to 50% of them have had an abnormality of the appendix. So it could be endo, obliteration of the tip, hardened piece of stool in the appendix, an injected appendix, aka more vascular. And lastly, we've identified some rare tumors of the bowel in the appendix as well. So in general, the risk benefit of taking it out is in favor of removing if they have endo in the pelvis. That's my approach.
Right. We had I didn't realize it was your study. We had Jaden Cohen present our opener of the season was all about the statistics that you just mentioned. So people can scroll back through YouTube to see that. I think another reason I used to see more in my earlier career was some surgeons take it because they don't want the teen to end up in the emergency room and they assume it's the appendix when it's actually something else. Have you heard of such a thing in your careers?
I mean, I think subconsciously, yes, it's one thing to not think about in the future with a differential diagnosis coming from the right side.
Yeah.
As for me, I tailor the treatment to the patient. And sometimes they come in and say, I've done my reading on the appendix. I know what immune function it has. Please don't take it out. I don't care if it has endo or not. And I will honor that request. But it's very it's really on a case-to-case basis. I usually recommend removal. I like the notion that you just mentioned. I don't have to worry about it in the future. But some people might think otherwise too. Iris, what are your thoughts?
I just wanted to add like the ACOG, or was it ABOG or ACOG, who came out with in one of the practice bulletins that said if the patient is under 35 it is not unreasonable. I think that was their words. I'm trying to recall exactly, to remove an appendix at a concomitant and another surgery because they're younger, they have a higher likelihood of developing appendicitis. So, and we do the same thing. What are your goals? What do you like? Risk benefit, and if the patient doesn't want it out, whatever they want is fine. It's their body. They make the decision. I just counsel them on all the different ideas. I let them ask questions, and whatever they decide, that's what I do.
Yeah, I think the groin pain patients, we like to really, especially if it's on the right, we like to start to think about that appendix in different ways also, right? Is that correct?
Yeah,
Mhm.
yeah. Presuming they have no hernias and their hip is fine, of course. Yeah.
Yeah. So, I'm curious. We used to talk more about it. I think the robot has changed the way our viewing field is during surgery. But with teens, is disease more subtle? Because there's always a discussion of you can't excise what you can't see.
So it's kind of like back to where we started with CY Lu when he was expressing to me what he didn't see in the OR, but he excised the high yield areas. I do feel that robotically you see better because of the 3D high definition. But if you know what to look for, if you know where to look for the increase in vascularity, you know the clear vesicles, the different appearances in teens, I think any skilled endosurgeon, if they understand what teen endo looks like, they'll excise it properly. I don't think they would, hopefully they wouldn't miss the disease.
I've seen in training a lot of, well, back when I was a resident. You're seeing the same screen with your attending who's helping you, and everything looked normal. And then we went into fellowship and they retrain you on how to look at things. And when it comes to adolescent endo, the bulk of it is not typical. It doesn't look brown. It's light in color. It's maybe just a wisp of scarred tissue, maybe a little bit more vascular. So on the macro view, when you're zoomed out, it looks fine. And you need to get really close. So whether on modern day laparoscopy or robotics, the how proximate you are to the lesion matters. So when I'm operating, if my head was in there, I'm literally this close with the scope looking at it to see all the detail that I need to see. But we don't see typical endo with adolescents. It's very subtle. And you need to retrain your viewing on how it looks so that you can suspect it and identify. 68% present with peritoneal defects, which are little breaks of the peritoneum. 44% have atypical white fibrotic lesions, and only 16% have the hemorrhagic dark red ones. So it's not typical. It's more like early disease features that requires experience to see.
Now, we all remember Dr. Redwine, of course, a close personal friend of yours, Dr. Iris. But he used to talk about that sometimes in teens, because the patient isn't fully hormonally developed, each lesion has not quite emerged yet. I know you've heard him talk about, because I'm looking at the look on your face. Are you seeing, is there anything you're doing preventatively aside from just a clean excision to make sure you're not going to re-op on a teen? Have you heard this, that sometimes the excision can't be complete because the lesions haven't emerged yet?
I have some thoughts here, unless Iris wants to
Yeah,
go.
share your thoughts.
I think it was interesting. When my first case when I moved out to California was a 15-year-old, and um, I knew that there was endo there. Just like the uterus was asymmetric, like it was pulled to a side, the uterosacrals were thickened, one was more thickened than the other. Initial path came out benign, like normal, no endo. And I went, and it was my first meeting with the pathologist. It was my first case when I began to be bicoastal. And I said, can you do deeper lesions? On my teens, I tend to see that endo is on a deeper cut. lo and behold, he went back and he recut those slides, and I forget, like two-thirds of them were positive. So I'm kind of guiding where my excisions are. I'm not doing just a superficial, and I'm not going deep either. I'm not doing anything crazy, and I'm not doing a wide peritoneal excision either. I'm I'm never always doing all or none. It just depends what my exam is in the OR, what I'm feeling, like where the blood supply is to know how deep or how shallow to go. But I do, whether it's they haven't emerged yet, and that's what David was speaking about, or I'm just seeing them sometimes deeper rather than on the surface, maybe we're talking about the same thing.
Yeah, yeah. And there's some studies that showed that in women who have no visible disease and you're highly suspecting endo, if you take random biopsies from the areas where it's commonly present, you'll see it microscopically in 25%, so one in four, which is not small given the bulk of normal laparoscopies that generalists are going to do. Nothing against generalists, but it's so important to add on to what Iris said. Like if I'm seeing an area that appears questionable, I will excise that area with a slightly wider margin of healthy tissue with the hope that we can identify those little spots that are microscopic. Complete peritonectomy, aka cut out everything where endo might grow, I think it's too aggressive, and the verdict on that is not out yet. So there's, I think, Dr. Megan Wasson out. I forgot where she was at, but Megan does a lot of is spearheading one of those research
Is
studies.
that
So
the Mayo?
yes, I know that, but I just can't remember where. I think Phoenix,
Oh, she's in
Arizona.
Arizona.
Yeah.
But she has a big study on that.
Yes, so that verdict is not out yet, but I don't think a full peritonectomy is warranted. But if I go in and I don't see anything, I'm going to do my four samples, one between uterus and bladder, one between uterus and rectum, and two from the pelvic sidewalls. Not massive, but big enough to get yield. And if those don't show anything, I'm usually feeling confident about the lack of endo in general.
I don't think our lay people out there realize the viewing field with the robot is so expanded. It's like having like a super extra amazing microscope to look like you're right up again. I know you did it too. We're doing the same thing, but it's not like years ago they were doing the peritonectomy just to see, but we now we are able to get right up against the lesion. So we did talk a little bit. We advertised this where we were going to talk about teen adenomyosis. I definitely see teens who have the endometriosis excision. We're confident in the excision. They have great physical therapy. They've downregulated their nerves. They've changed their diet, so they say, and they still have horrible cramping, back pain, bloating, and clotty periods. Are you seeing a little bit of you? We really used to think of adenomyosis as an older woman's disease. Are you seeing adenomyosis in young patients?
Yeah,
Yes.
yeah, of course.
Yeah.
And what are you doing for them?
So I like to exclude all pain generators and leave adeno as the only one that's there, and then see what their symptoms are, and then speak to them about if heavy periods or clots are their big symptom. I had medical management with birth control, or if they're sexually active, in IUD, and if their I only put in an IUD if their pelvic floor muscles are relaxed, like they've been through pelvic floor PT. But an IUD can be really helpful with the understanding and the proper counseling that for the first 6 months after IUD insertion, they'll probably have a lot of very irregular bleeding. Like that is par for the course with an IUD. So I think it's important for patients to fully understand that. Because so many patients come into my office, they're like, yeah, my doctor put an IUD and I've had irregular bleeding for 6 months and I want them to just pull it out. I'm like, well, that's gonna happen. So um, I try to exclude everything and treat everything.
Yeah.
Uh, I'm gonna add one more thing here too. So adeno is a surgical diagnosis. Like you would need the hysterectomy to find out about it. So obviously we don't do that for adolescents. However, it's clinically suspected by flow and pain. And it's also, you supplement your suspicion by doing ultrasound slash MRI. If there's any suspicion of adenomyosis in the uterus from imaging, the risk of it present within the realm of painful cycle is around 8 to 10%. So that's not low. And if you look at adolescents, it's 1 in 10 roughly. And so if there's suspicion in that sense, or you operate on them and you find out that their uterus looks a little rubbery, boggy, purplish hue to it, maybe there's adeno there, absolutely consider placing an IUD at the time of surgery to suppress that moving forward. It's not diagnostic, but if you suspect it on imaging and on surgical assessment, there's no reason why you shouldn't consider talking to to your patient about it. So those are my thoughts on it, and it's present. I've seen it. I've seen adenomyomas in adolescents, and I've also seen adenomyosis as well.
Are you taking the adenomyomas in a young patient or you're leaving them?
It depends on their size and their location because location is key. If it's close to the lining, you risk scarring their lining, which is a huge deal. If it's well encapsulated, present in an area that's resectable, I will offer that option to them, of course.
Now, can you clarify for our viewers, why is an IUD maybe with progesterone so important with adenomyosis, whereas it's not as important with endometriosis?
I think it's important for both.
I know, but so I'm trying to get you to say it instead of me. So we know with adenomyosis that that progesterone direct to the lining
Yeah.
can be very relieving of symptoms for some, not for all, as opposed to oral progesterone. Do you see a difference between the two with adenomyosis, or were you looking up the stat? I may do.
I'm not. I'm not. I'm
Oh,
actually looking at my uterus right here
oh,
because
I
yes.
love your
I'm
models.
gonna use this for the discussion here. So when it comes to adenomyosis, I prefer locally acting, aka something in the uterus, in the actual lining right there. So the IUD sits right here, suppresses the adeno, which is in the wall of the uterus. It has such a great effect locally. It does not suppress ovaries. So you'll still have ovulation, you'll still make estrogen, progesterone. So I think in our patients that are adolescents, an IUD works great for adeno, maybe not the best for endo, which is further out from the uterus. And so my go-to is an IUD if I can, if they're convinced to try it. In terms of side effects, less side effect profile than non-implantable options. And then the effect is so much more effective at the uterus. And I want them to give it a 3 month trial. Adequate trial is important. If you can get the 3 months in, then we have a good idea what long term is going to look like.
Yeah, no, once you watch our estrogen lecture at the summit, you're gonna love the IUD in a teen because they're still getting their natural estrogen, which also means their brain is still getting their natural estrogen. Their heart is still getting their natural estrogen. It's very interesting. Now, some patients, Dr. Vidal is big on this one. The certain IUDs are meant to last 5 years, and that's for birth control. But for adenomyosis symptoms, oftentimes that level isn't kept even enough for the 5 years. Do you ever have people replace them at 2.5?
I see patients often, sometime it's at year 4 or year 3 where they're like, I was suppressed, I wasn't bleeding, and all of a sudden I started to bleed. So I do hear patients report that.
And I know you are there any other like interventions? I know we talk about PT because I'm a PT, but are there any other interventions that are outside like the maybe the GYN lens that you try with adenomyosis? I know anti-inflammatory diet becomes important. What else do you try?
We're going beyond the spectrum of hormones.
Yeah, beyond the spectrum of hormones, because not, maybe they're doing hormones. What else can they can they do? I used to have a when I worked in New York, I had an anesthesiologist. I even forget what he was. He used to time the injection every 4 weeks in certain patients to block a certain area of the spine. There were certain things that they would do. What else do you guys add in? Maybe you don't do it. Maybe you refer out.
I like to recommend like CBD suppositories for patients. They can put them in vaginally or rectally. It depends if their pain typically is around their menses, around their cycle. And if they're, let's say they have their period every 28 days, I have them start it maybe 2 days in advance. If they happen to have a bathtub, like starting an Epsom salt bath prior to their period. But CBD suppositories just work great. Other patients respond well with vaginal Valium and some baclofen and some gabapentin. Sometimes people can have lidocaine, and there's all these different concoctions. But I find those to be really helpful for for the teens. I prefer the CBD, and it tends to work really well with them.
I think that notion of, you just said a great thing. Suppositories are not always just vaginally. If you have a lot of adenomyosis in the posterior uterus, you're going to get a good amount of relief from using that suppository rectally.
Yeah.
And lots of people forget to tell patients that, right?
Yeah, I find I use it post-surgery actually because I don't want patients putting anything in vaginally after a surgery. And as part of their pain management post-surgery, is our vaginal baclofen, Valium suppositories or CBD suppositories. Obviously, I don't prescribe it just afterwards. If they've taken it before and they benefit from them, we use that to minimize narcotics as well in patients.
All right, I'm just checking all our questions. So the Endometriosis Summit is coming up very quickly. And it's March 28th through the 30th, 2025 in Celebration, Florida, and virtually from anywhere in the world, across basically three entities. We have virtual, we have in person, and then we have a Spanish summit. And across all three entities, we have 447 people registered as of this morning. And I'm going to tell you, that Spanish summit is pulling its own weight. I really have to throw myself into that Spanish summit tomorrow, make sure it's going to be okay. So, what do you guys look forward to? I know, like, you're there with us in spirit. You've never really missed one because you're always there with us in spirit. Yes, the first one, you were there. So, what are you looking forward to about this year's Endometriosis Summit? We'll start with you, Iris.
I
There
think,
in spirit. Don't worry.
yeah, no, I have like this compersion. I'm so excited to witness this collaboration amongst different providers and patients and different disciplines. And I love the collaboration. And like you just mentioning, talking to people by physicians by their first name. I think we can learn so much from patients. And I think patients are what is driving endometriosis treatment. It's not physicians, it's not insurance companies, it's not pharmaceutical industries, it's patients. Like they're saying enough is enough. So I love that you partner with patients. And I love your energy and your spirit, and I will be there in spirit.
I know. We're
I
gonna, we
just
all,
have,
so it was interesting because a few weeks ago I was in Washington, D.C., and I did a day on the Hill, and I have big things planned for the endometriosis world. But the keynote speaker was a news anchor, a female news anchor of all people. And she was talking about how, in order to show that you're not Dr. Google, that doctors should wear their white coats everywhere. And I'm like, no, like we're not showing that the doctor's here and the patient is here anymore. Those days are over. And it's doctors are partners with patients. You should throw the white coat in the garbage. And this did not go over well in the room of 300 urologists. But I think the endometriosis summit is sort of about that. And I think to the chagrin of, maybe we have some doctors on our program who aren't used to that. And it'll be interesting to see who actually writes their first name down on their badge.
Can I throw out one other thing that I really admire about you, Sally, and what you put into the endometriosis summit is that you speak about the trauma lens and the medical gaslighting and the trauma, which, patients are told you're fine. There's nothing wrong with you. Your imaging is normal. And I think it's such a key component to be addressed. And I think you're really the first one in the landscape of the endometriosis world who's making that a priority. So I really do applaud that because I think that healing the trauma lens is as important as healing the pelvic floor PT, as important as healing the gut, as important because if the mind is the mind gut connection is everything. And the inflammation gut connection. So I just applaud all the work that you're doing on that.
Yes, we have her name is Francie Fitzgerald, and she's a connective tissue patient, but she's a social worker who's going to teach, you're going to love it. Thriving after medical gaslighting.
Wow.
Flourish in the face of trauma. That's the name of because it is about the patient thriving. That's on Saturday. She has 2 hours to do that. It'll be very, we had to do lots of things for that. So, Rayan, you're joining us in person, apparently. What are
Yes,
you looking forward to the most?
the celebration of advocacy and awareness. Like when I went to the summit last year, I was shocked. I've never seen a conference that had patience. And that really,
Really?
I've never seen a conference that had patience. I am being honest. I've never seen that. So for me to see that, because when I'm with patients, and this has been my norm, I've never had a white coat on for the past 10 years.
Yeah,
Literally, because
it's
I don't
definitely
care
not
for
your
that
style.
stuff. I don't care for that stuff. I'm more level with the patients. Um, it was very eye-opening. And so for me at this point, it's just a repeat. But now I know more. I'm happy to be part of it and engaged. And I feel like so much more of endo is known now compared to the past decade. But there's so much work to do. So being part of this whole effort is an honor.
Yeah, well, there's a new branch of the summit emerging when you talk about being part of effort. So, hold that thought. And it
I'm
was
super
great to
excited about the cadaver, though.
yeah, we
That'd be
have
great.
Dr. Ceccaroni doing the cadaver. And Dr. Vidal is gonna do the lung dissection on the robot, which should be really exciting. And the bane of my existence. And that portion still, and we have CUs for PTs for the first time, which was big anyway. So, all right, we will see you. We will not see you. Well, we see you in person next week, but we have one more episode of Endo Summit Live, and we're going to talk about menopause and hysterectomy and ongoing endometriosis, and it should be a lot of fun. We'll have 3 brand new to Endo Summit Live faculty next week. So, see everybody. Thank you for joining us.
Thanks, Sally. Have a great evening.
You too. Thanks for joining.
Thanks, Sally. That was amazing.